Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. All right. Hi there. Welcome back to the Breast Cancer Podcast. We have the famous Dr. Shabana Dewani with us today. She's a medical oncologist here in Columbus, Ohio. And we have a lot of mutual patients, unfortunately diagnosed with breast cancer in their pregnancy. And so we're going to tackle the topic today is pregnancy associated breast cancer. Well, what is it? Well, the definition of pregnancy associated breast cancer is the breast cancer diagnosed during their pregnancy and up to 1 year postpartum is the definition of a pregnancy associated breast cancer. And in the United States, 1 in 3,000 women will get diagnosed with pregnancy and breast cancer during pregnancy. It is the second most common cancer after cervical cancer. And, we are, as women, we're delaying childbearing into our 30s now because of personal and professional reasons. So women are putting off having kids too much later, And so, what are some normal changes that happen for these women as they're, are diagnosed they're pregnant? What are the normal changes to their breast? Well, some things that happen is your breast enlarges. There is a darkening of the areola. There's what's called Montgomery tubercles. Those are the tubercles on the areola. You can see, bigger Montgomery tubercles. Sometimes you can see some milk production or some clear liquid from the nipples, which is, colostrum. And protrusion of the nipples is something that we see. And you can see blood vessels on your breast, just from enlarged breast during pregnancy. So
Gosh, that probably is making very challenging for the patients to
yeah,
with
yeah,
all those changes to feel like what's a normal lump versus like breast
right,
cancer
right,
that would could be there.
right.
So how do you counsel in terms of diagnosing? Like how do you approach somebody with pregnancy
Yeah.
presenting with a lump or concern for a breast
Yeah,
cancer?
that's actually a very good question, Dr. Diwani. And I think sometimes there is a delay in diagnosis in women who are pregnant because it's difficult to really feel a mass, or you get confused between normal changes that happen in pregnancy to a mass that's found from cancer. So, what I say is if you're feeling a mass in pregnancy, whether it's felt by your physician or yourself, make sure you be your own advocate and go talk to your doctor, your provider, and they typically will get an ultrasound. That's how they get started.
Okay.
Yeah. So an ultrasound, and if there is a mass that looks suspicious, they'll biopsy. They'll also get a mammogram. American College of Radiology has said it's now safe to get a mammogram for women in pregnancy. They
Good.
typically shield the abdomen or the belly. And if the mass is suspicious, again, they get a biopsy. They put a clip in that region, and we wait for the pathology results.
Okay.
And
So as far as a female feels the breast, you go through all this diagnostic. Are they always malignant or do you see any benign
yeah,
form?
that's actually a great question too. We talk so much about cancer. Women are so anxious about it. When they feel a mass, they think it's cancer. Actually, most commonly, what I see in pregnant women is a fibroadenoma or an other entity called a lactating adenoma. They're both benign
Okay.
masses, and they grow in presence of hormonal changes. So there's a lot of hormonal changes that's happening in the breast as a result
Okay.
of pregnancy. So we see those masses, and again, we biopsy them. and just kind of follow them. Sometimes the masses become smaller because once they have a baby, the hormones decline, so the masses may shrink down. If they remain large or growing or causing pain, we do typically remove it after the
Okay.
delivery of the baby.
Okay.
So
Good to know. You never fail to learn with Dr. Halaharvi.
so, Dr. Dewan, I have a question for you. What types of breast cancer are commonly found in pregnant women?
So in pregnant female, like, usually when we talk about pregnancy associated breast cancer, we worry about they being more aggressive. The reason is about 70% of them are triple negative,
Yeah.
which is considered as an aggressive subset of breast cancer. And because of all the changes, it's very hard for a normal female to recognize what's normal, what's not
Yeah.
normal. So they're present in advanced stages. So about 67% of patients who present have lymph node positive disease. So mostly triple negative and more advanced when we see them in
Wow.
right,
So does that
pregnancy.
mean that they need like systemic therapy then if they're diagnosed with triple negatives?
So as far as when we talk about systemic treatment, a lot of it depends, like where they are
Yeah.
in their trimester,
Yeah.
where they are in terms of the stage of the disease, and what is the biology of the disease.
Yeah.
All those factors come into play when we talk about how we approach these patients, because typically in first trimester it is very
Yeah.
hard
Yeah.
to perform any surgeries or give systemic
Yeah.
treatment. When it comes to systemic treatment, it would really depend if this is a triple negative breast
Mhm.
cancer or locally advanced hormone positive breast cancer or something called as HER2 positive breast cancer. So the chemotherapy regimens that we would utilize in second and third trimester really depends what exactly how we are approaching, whether we would be doing chemotherapy or we would be doing surgery. So I would bounce back that question
Yeah.
to you.
Yeah.
If based on their tumor, if you decide to go for surgery, how do you counsel the patients or
Yeah.
walk through the
Yeah.
surgical options?
So again, it's when we talk about personalized care for these women, it's never been more true for pregnant women, right? So it all really depends on what stage of the cancer they're diagnosed with and the size of the tumor and at what trimester. So if they're in their first trimester, surgery is not contraindicated
Okay.
in the first trimester, just because the effects of anesthesia on the fetus, we do worry about congenital malformations with the effects of anesthesia. So it's okay to perform surgery in the second and third trimesters. But when we talk about breast surgery, if someone can have lumpectomy or breast conservation, which is just removing that area of the cancer and some normal tissue around it, they typically need radiation. Typically, radiation is contraindicated in
Okay.
pregnancy. So they cannot have a lumpectomy in a second trimester for that reason. I have performed a lumpectomy in a third trimester,
Okay.
and then they go on to have radiation after the delivery of the
Deliver the
baby.
baby.
Yeah.
Okay.
So it really depends on the size of the tumor, what trimester, and then the hormone receptors. And you and I have talked about several of our mutual patients who are pregnant and have had breast cancer or diagnosed with breast cancer. And we talk about them at our multidisciplinary conference,
Right.
where there are other experts, medical oncologists, radiation oncologists, radiologists, pathologists, genetic counselors, and we come up with the best treatment plan for this patient. So it's not even what I want to do for them or Dr. Dewani is like the whole multidisciplinary team. And I think I'm going to make a plug for the multidisciplinary conference. Whatever, the hospital system you're, getting your care, make sure your physicians are presenting your case at the multidisciplinary conference, because that's where you get the broad knowledge. You're putting all these experts heads together and coming up with the best treatment plan for you based on the recommended national guidelines.
Yes, that is very important
Yes.
point that you pointed out. Like, because in that conference, we actually look at your images. The
Right.
radiologist points out to key findings,
Yeah.
which are important for surgeons for
Yeah.
their surgery.
Yeah.
It is important for a medical oncologist how we plan out your treatment, and having other ancillary supports there, radiation doctor, present there. So I just feel like it's such an important part of what we do on a daily
Right.
basis.
Right. Exactly. Um, so for these patients, is chemotherapy safe during pregnancy?
So, good question. We do utilize chemotherapy in pregnancy, but that first 12 weeks or the first trimester, when baby's organs are forming, we cannot use
Yeah.
chemotherapy because, you know, how
Same
you taught,
same
same like
concept.
that
Yeah. Yeah.
surgery with
Yeah.
anesthesia, it can increase the risk for congenital malformation. So first 12 weeks, we don't do chemotherapy. After 12 weeks, yes, there has been a lot of data in terms of safety of certain chemotherapy regimens that could be utilized in pregnant patients. Something that we commonly use is called AC. The timing of it is a little bit different how we would give in a pregnant versus a non-pregnant female. We also make changes with their nausea medications, the pre-medications they receive, so that the crossing of those drugs through the placenta is minimized. So the effect on the baby is minimal. As far as, so it's safe to do chemotherapy in the second and the third trimester of pregnancy based on what regimens we are using, as we are seeing more and more pregnancy associated breast cancer just based on where the childbearing age of the female is falling. Um, we are getting a little bit more data in terms of what all is safe in pregnancy. There are certain biology of tumors, something like HER2 positive. It is very important to have anti-HER2 treatment,
Mhm.
but we can't utilize that during pregnancy. So once a female delivers, and that's something that we would really want to utilize to give. So, but there are other regimens that we can try and use during pregnancy to bridge them until the delivery or their
Yeah.
induction,
Yeah.
and then utilize the anti-HER2 treatments.
Yeah, yeah. Wow, that's really great information. We've come a long way. When I was in fellowship, I don't think quite a few drugs were utilized during pregnancy. And I think that's another reason it's really important to go to doctors who keep up with the research. And Dr. Dewani does a great job. We go to conferences. We've gone to several conferences together. And it's important to be with a doctor who keeps up with the research because things change really drastically. And so can a woman breastfeed after, after having, so they go through the treatment, have the baby, are they allowed to breastfeed?
Yeah, so if they still have their breast in place, like, if they've had lumpectomy, they're going to need radiation. So it
Right.
becomes
Yeah.
challenging. If they go on anti-estrogen treatment, we do not recommend feeding while they're taking hormonal treatment. So
Correct.
that
Yeah.
becomes challenging. And then if they're on chemotherapy, again, they can't breastfeed while they're getting systemic
Right.
chemotherapy.
Right.
So that's one of the big challenges that, the
Yeah.
breastfeeding pretty much is not feasible after, if there is a pregnancy associated breast cancer and they're having active treatment for
Yeah,
it.
yeah. So, one thing too is there's milk banks. In your
Great.
community,
Yes.
in your city, you
Yes.
can find milk banks. In our organization where we work, there is milk banks that women donate milk, and so your baby can still have breast milk. It just may not be your milk, but our goal is to get you to the treatment, go into successful recovery, and have great prognosis, and have all those years with your baby in the future. So this has been a great conversation. Unfortunately, in the United States, we're diagnosing younger women with breast cancer, and some of these women have tend to be, childbearing age. And breast cancer is the second most common cancer after cervical cancer in pregnancy. But what I want to say is, just be your own advocate. Make sure you're doing your exams. There are changes that happen with pregnancy to your breasts. But if you're feeling a lump or it doesn't feel right, make sure you talk to your provider. They can get an ultrasound, a mammogram, and work you up and send you to a breast surgical oncologist or a medical oncologist, so we can then take it from there. And if it turns out nothing, it's a benign mass, which is usually what happens most of the time, is what I've seen. But at least if it is going to be cancer, we want to diagnose it as early as possible. So less invasive treatments, less surgery, a great prognosis. And our goal is to get them through this chapter of this diagnosis to their new normal, and for them to live their best life.
Right.
And so
Yeah, and other thing I wanted to point out about the
yeah.
staging. So sometimes it's very difficult to
Yeah.
stage because you cannot get all your routine
Oh, that's
scans
correct.
while
Yeah.
somebody's
Yeah.
pregnant for the risk of radiation.
Yeah.
But we try to get as much as staging, at
Yeah.
least some minimal information once we decide a treatment plan.
Yeah.
So we typically shield the abdomen, get a chest x-ray, we do a complete abdominal ultrasound
Yes.
to make sure there is nothing that we are seeing. If they have additional symptoms like back pain, we might end up doing MRI of the entire spine to make sure everything is looking good.
Yeah.
So those are different, at least a way of trying to get whatever information we can before we have a treatment plan. And then if they are high risk, or we worry about, like, they having additional disease, then at least after they deliver, we would like to get a little bit more refined scans
Yeah.
with CTs or PET afterwards to make sure that as far as we are not detecting any disease anywhere else.
Yeah. Yeah.
And when we talk about delivery, so this is, like you mentioned, more
Yeah.
of a team approach. We do work with your OB,
Yeah.
your high risk OB, in terms of how we plan out your timing for the delivery, because we have to, if you are on chemotherapy, we have to stop that chemo at least 3 weeks before
Yeah.
your delivery, because we want to make sure that your blood counts are all up, your white cell count up,
Yeah.
because we want to prevent you having
Yeah.
infection
Yeah.
during your delivery, whether you had a normal or you had a C-section. The other thing is we want to make sure your platelet count is up, and so are the counts of the baby are up, so that way we potentially decrease the risk of infection or bleeding in that peripartum or postpartum period.
Yeah, those are all really great points. And I think one thing we didn't touch on is the genetics.
Yes.
Genetic testing is really important because if you're childbearing, if you're pregnant, you're younger age, so you would want to get genetic testing. And how does that play in the role of the treatment, the genetic testing?
So typically, as when they're pregnant and undergoing treatment, it truly wouldn't affect that particular. But
Yeah.
once they deliver, and based on certain biology of tumor, for example, triple negative, and if their genetics is positive,
Yeah.
it would affect some of the medications that we may utilize afterwards, something called as PARP inhibitor. It would impact your surgical decisions
Yeah.
in terms of if you have a genetic mutation present, or your future screening imaging that would
Yeah.
take place.
Yeah, that is correct. So the take-home message is prompt evaluation of any breast mass is really warranted to delay diagnosis and the treatment for women who are pregnant. And the treatment during pregnancy is very similar to women non-pregnant, just with a little bit of changes, modifications for the fetus. But good prognosis, early stage cancer. Make sure you're vigilant with your breast exams, and come see us if we are happy to help you. Sorry you're diagnosed with breast cancer in pregnancy, but don't lose hope, and we can take care of you. So
Absolutely, absolutely. I think this was a great segment, and a great information for our patients out there. If you have pregnancy associated breast cancer, make sure you have as much knowledge as possible
yeah,
to make the right
correct.
decisions. Thank you, Dr. Halaharvi, for doing an amazing job in our Columbus community, and not only helping Ohio, United States, but throughout the world.
Yeah.
It's just amazing to see how your podcast has flourished
Yeah,
over the
thank you so
years.
much. It's because of people like you and experts like you. And we also actually recorded a podcast on fertility after breast cancer. And so, that would be a good segment to listen to. It kind of goes in line with what we just talked about. But you can have babies after going through breast cancer. So there is hope for every aspect. It's just that you want to be advocate for yourself and empower yourself with knowledge. So thank you so much, Dr. Dewani, for taking the time to be on the show today.
Absolutely,
And
absolutely.
give us a 5-star rating and share this episode with others if you found this to be beneficial. And thank you so much for taking the time to listen to this podcast. Take care, everyone.
Thank
Bye-bye.
you.
Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice.